So now we'll talk about initiating and optimizing clozapine. So how do we titrate clozapine? Well, let's review first the manufacturer's guidelines, which recommend an initial dose of 12.5 milligrams once or twice daily. The dose is increased by 25 to 50 milligrams per day, if well tolerated, to a target dose of between 300 to 450 milligrams daily by the end of week 2. Then subsequent dose increments should be made no more than once or twice a week, not exceeding a change of 100 milligrams. The guidelines recommend cautious titration and potentially divided dosing to minimize risks of adverse effects, including orthostatic hypotension, seizures, and sedation. The maximum daily dose of clozapine is 900 milligrams per day. In contrast to some of our other psychotropic medications, where sometimes we have off-label dosing above the FDA maximum dose, I would strongly contend that 900 milligrams is a hard ceiling for clozapine dose, and I never go above 900 milligrams a day. Importantly, it's mentioned an issue that if treatment with clozapine is interrupted for 2 to 3 days for 48 or 72 hours, that retitration is recommended. The issue of interrupted treatment, for me, most commonly occurs in the context of patients who can't get their blood drawn, and so the pharmacy won't dispense the medicine. This often occurs when a blood draw happens to fall on a weekend or a holiday. And there are several workarounds for that. Number one, the new clozapine REMS system allows for a clinician discretion option, whereas the patient status form can be completed even without the blood draw in hand. If, for example, it's a patient who's been stable long-term on clozapine and they couldn't get labs done because their usual blood draw day fell on a holiday during the week. And so that option to put in a clinician discretion can allow the patient to get the medicine and they can go get the blood work as soon as possible thereafter. The other option, if we run into an issue with getting the blood drawn, is I have advised patients that on weekends or holidays, it is possible to present to a local emergency department for a blood draw only visit so that they don't have to wait in triage for hours. At least our emergency department is set up that if patients need a therapeutic monitoring blood draw on a weekend or holiday, those patients could, in a pinch, present just for the blood draw. So what's the speed of clozapine titration? I'll share with you kind of the typical titration strategies that I use. I have different strategies, whether the patient is inpatient versus outpatient. Because of the extensive monitoring on inpatient units, we tend to go much faster. So for inpatients, I will start 25 milligrams of clozapine on day 1 and increase that by 25 milligrams per day up to day 4, so that by day 4, the patient's on 100 milligrams. Once we get to 100 milligrams a day, we increase the clozapine dose by 50 milligrams per day thereafter. We can hold at a given dose for an extra day or even 2 days based on tolerability issues. We typically divide the doses initially, but it's important to note that if a patient has significant sedation, we may opt to consolidate the medicine at bedtime, even in the first couple of days. And our endpoint for the clozapine titration is based on either symptomatic response or tolerability issues such as dose limiting, sedation, orthostasis, or tachycardia. But otherwise, we would continue to titrate clozapine based on symptomatic response until we see either near or hopefully full remission, particularly of positive symptoms. By contrast, on an outpatient basis, rather than increasing initially by 25 milligrams a day, there are some cases where on an outpatient basis you could titrate more rapidly, but on average, I find it's easier for patients and families to increase the prescription just on a weekly basis. So I do 25 on week 1, 50 total on week 2, 75 week 3, and 100 week 4. Same as inpatient. In outpatients, after we get to a dose of 100, we increase by 50 milligrams a day thereafter. So a couple of psychopharmacology pearls for you regarding clozapine. So clozapine gets metabolized to its active metabolite norclozapine, primarily by cytochrome P450 CYP1A2, but also 3A4. So as a result, people who are CYP1A2 ultra-rapid metabolizers or patients who are cigarette smokers, which upregulate the activity of 1A2, those patients may experience lower clozapine blood levels even at higher doses. By contrast, it's important to note that the antidepressant agent fluvoxamine is a strong inhibitor of both CYP1A2 and 3A4, and therefore can increase blood levels of clozapine by 500%. So what's the target dose of clozapine? Well, no specific therapeutic levels have been established, but blood levels of clozapine are available, and the typical reference range for clozapine is a level of greater than 350. We also, with that, get levels of the active metabolite norclozapine, and then the reference range for the total of clozapine plus norclozapine is greater than 450. So what we see is that on patients who are on a dose of at least 400 milligrams per day of clozapine for 4 weeks, those patients were most likely to have a significant therapeutic response to clozapine plus norclozapine when the total clozapine level was greater than 450. But with that, what I would say is that patients show a tremendous variation in both their symptomatic response to clozapine as well as side effects. So what we see is that in patients with treatment-resistant psychosis, I would say the average final dose is about 400 milligrams per day. But the typical range for response is 300 to 900 milligrams per day. I would say 300 to 600 is a middle of the road clozapine dose. Low dose clozapine, which some patients respond to, which would be doses less than 300 milligrams a day. And then we have other patients who need higher doses of clozapine in the range of 600 to 900 milligrams a day for an adequate response. So an important pearl here is, what do we do with the pre-switch antipsychotic when we start our patients on clozapine? So there's really minimal evidence in the literature to guide how we stop the pre-clozapine antipsychotic. I would contend that unless there's some urgent need due to a serious adverse effect, that it's common to start tapering off the pre-switch antipsychotic when we get to a clozapine dose between 100 to 200 milligrams per day. And that's the strategy I use in my clinical practice. And so that said, the dose of the pre-switch antipsychotic can be reduced based on clinical response to clozapine. And so if the patient's getting rapidly, significantly better, we could potentially reduce the pre-switch antipsychotic earlier or more quickly. I would say one approach is to reduce the dose of the pre-clozapine antipsychotic by about 1/4 once or twice weekly, typically once a week in the outpatient setting, or could be done twice weekly as an inpatient. So again, the speed of tapering may be influenced by clinical setting. But again, my rule of thumb is that I want to reduce the dose of the pre-switch antipsychotic by about 25% per week. So if the patient's on 20 milligrams of a particular antipsychotic over 4 weeks, I'm going to taper them down from 15 to 10 to 5, and then to finally stopping the medication. So in summary, the guiding principle of clozapine titration is truly start low and go slow. Although it can be titrated more rapidly in inpatients, the average target dose of clozapine is 400 milligrams per day. Blood levels can help guide our titration. And I would advise you not to taper the pre-clozapine antipsychotic until you get to a dose of 100 to 200 milligrams per day of clozapine.